the next paper. After having diagnosed how the metastasis can be diagnosed, we go how it has to be treated when surgery has to be done by Professor Mitsuya from Japan. Professor Mitsuya, can you please share your slides, please? Problem.
Thank you, Dr. Panigrahi and Dr. Girelli. I'm honored to have the opportunity to give my talk. I'm Dr. Mitsuya, Division of Neurosurgery, Shizuoka Cancer Center in Japan. Today, I'd like to talk about management of brain metastasis, especially regarding surgical indications. These are today's contents. Surgical resection plays an important role in the management of patients with brain metastasis. Standard indications for craniotomy include 1. Diagnostic uncertainty. 2. Brain metastasis causing symptoms refractory to steroid. 3. Bulky metastasis, typically 3 or 4 centimeter oversize. 4. Solitary brain metastasis. Importance of pathological and molecular diagnosis. This case, suspect of lung cancer, but bronchoscopy is difficult, challenge 2 times failure. So, suspect of brain mets, surgical resection, pathological diagnosis, non-small cell lung cancer, TTF1 positive. PD-L1 tumor population score is 60%. Molecular diagnosis, driver mutation negative. So, systemic therapy, immunocheckpoint inhibitor be effective. Now, this is a preoperative prognostic marker. We report preoperative neutrophil to lymphocyte ratio, NLR, related to cancer and inflammation and cancer immunology. On terminal stage, NLR increased. Median overall survival after resection brain metastasis, NLR under 5 is 14 months, but NLR over 5, only 5 months. Predictor of worse survival after resection. Surgical resections advantages resolution of mass effect and edema immediately. Rapid steroid tapering. Rapid neurological recovery. Simplified radiographic interpretation. Recurrence versus radiation necrosis. Histological confirmation of the region. Disadvantage may cause delay of primary cancer treatment. Requires general anesthesia. Invasive procedure. In the era of development pharmacotherapy, prognosis of the patient with surgical resection of brain mets is improved. This paper, non-small cell lung cancer BMETs. After resection BMETs, median overall survival, surgery plus radiation therapy and chemotherapy is 11.8 months. But surgery plus radiotherapy and immunocheckpoint inhibitor is 23 months. So A long survivor. Next theme is improve local control and avoidance of leptomeningeal disease and reduce of adverse events, cognitive function, and radiation necrosis important. Next, two methods of surgery for brain metastasis. Near eloquent area, recommended minimum resection. Near pyramidal tract, minimum resection is recommended. Dissection of gliotic tissues, don't dissection on the tumor. And insert cotton putty around tumor margin. Infiltrated tumor cells in brain, risk of local recurrence. This paper is very important from BOMAT. Non-small cell lung cancer and sarcoma, breast cancer, brain metastasis. Mean depth of infiltration is 1 millimeter, but small cell lung cancer and melanoma mean depth of infiltration is 2 millimeter over. Risk of local recurrence. This paper is Mahajan from Mahajan, MD Anders Cancer Center. Problem after surgery, local recurrence. Surgery alone versus surgery plus SRS phase 3 randomized control trial. Surgery plus observation, local recurrence 6 months, 34%. Local recurrence 12 months, 57 months. Very high rate. Surgery plus cavity SRS, local recurrence 6 months, 15%, 12 months, 28%. Non-eloquent area, we recommend removal of safety margin. Non-eloquent area, uncapping technique and removal with safety margin, improve the local control, protect leptomeningeal dissemination. This is salvage surgery for local progression of brain metastasis previously treated with STI. Recurrence after STI, tumor margin is irregular. So we recommend fence post method, removal with safety margin. Median overall survival, 20.2 months. Two removal techniques of brain mets. Piecemeal resection, deep and large tumor, eloquent area, less invasive for surrounding brain, but high dissemination risk. This is dilemma. Unblock resection, superficial and smaller tumor, non-eloquent area. Piecemeal resection is leptomeningeal dissemination high-risk case. This paper report unblock resection is 3% incidence of LMD, but piecemeal resection is 9% incident of LMD. Advantage of neoadjuvant SRT, I think. Problem after surgery, risk of patchy meningeal failure. This paper also piecemeal resection is high risk. We report intraoperative cotton dam wash cytology. Diagnosis of intraoperative LMD and prevention of postoperative LMD. Next, neoadjuvant STI background. Large brain metastasis randomized control trial. A partial report, surgery plus postoperative WBRT. Long survivor, cognitive function down. Surgery plus post-op SRS, Mahajan and Brown. Surgery plus salvage SRS from Kayama in Japan. New strategy, neoadjuvant SRS followed by surgery. Postoperative left meningeal dissemination improve. Symptomatic radiation necrosis improve. Our institute, 20 patients, small case series, pilot study, 5 fraction SRT, neoadjuvant fractionated stereotactic radiotherapy, followed by piecemeal resection of brain metastasis. Local recurrence is 5%. Left meningeal metastasis, 5%. Symptomatic radiation necrosis, 0%. Representative case, lung cancer, premotor region, 4.6 centimeter. Large and deep metastasis. Hemiparesis, very severe. KPS 60. Preoperative SRT followed by piecemeal resection. After surgery, KPS improved. Hemiparesis improved and systemic therapy. Small cortical incision and run nearby very cortical vein. Small cortical incision and piecemeal technique needed. Prospective study in Japan, PI is Mitsuya. Now is ongoing. 57 patients in Japan. Brain metastasis 1 to 4. Maximum diameter 2 to 5 centimeters. Neoadjuvant SRT 5 fraction within 14 days surgery. MRI follow-up every 3 months. Primary endpoint, local control. Secondary endpoint, symptomatic radiation necrosis and left meningeal dissemination, and so on. Preoperative SRT advantage and disadvantage. Potential advantage, local control, improve. Left meningeal disease and radiation necrosis avoid. Disadvantages: lack of pathological confirmation before SRS. Not compatible with emergent surgery. Next, palliative CSF shunting for left meningeal metastasis related to hydrocephalus in patients with lung adenocarcinoma. We report 31 patients. Post-op performance status improved, TKI per os. PS 1 to 2, median overall survival of 7.7 months. CNS BBB intraperitoneum, no barrier. So after surgery, systemic chemotherapy, TKI or ADC, carcinomatous peritonitis avoided. Box regression analysis, ECOG PS at diagnosis of LM, and controlled extracranial disease, post-shunt TKI. Important of early diagnosis. Early diagnosis of left meningeal metastasis is important. This is non-contrast enhanced type left meningeal metastasis. Clear hyperintensity along the brainstem surface in left meningeal metastasis. Our hospital, all cancers from LMD, bloomy line sign, 11 patients, 7.7%. All lung cancer adenocarcinoma, EGFR positive cases. We report bloomy line sign, bloomy line cheese like diagnosis, sugar coating type is too late. So this phenomenon is early diagnosis of left meningeal important. This is last slide. Management of brain metastasis surgical indication. Overall survival is improved. The patient with brain mets after surgical resection in the era of STI and developed pharmacotherapy. Tasks: improve local control, avoidance of LMD, reduce of adverse events. Multidisciplinary approach is important. Thank you very much.
Yeah, thank you, Professor, for giving a lucid lecture on when to operate and what is the role of pre-radiation for and surgery in metastasis. We'll have the questions and answer after all the three lectures, and I request you to please